A very good afternoon to all. I'm Dr. Rahul Kamble. I am a MD microbiologist and presently the project lead for Antimicrobial Stewardship for an associate with the Americares India Foundation. It is esteemed a pleasure to speak on the esteemed platform of Melap on my topic of my passion, that is inpatient control through antimicrobial stewardship. We'll wait for a few minutes, for 3 to 4 minutes. Let the other group of participants join, and we'll then begin. Is my screen visible and I am clearly audible? Yes, Rohit. Am I audible clearly?
Yes, sir. You're audible.
Okay, we'll begin with my presentation then. The agenda for today's presentation is to cover what is antimicrobial antibiotic, check in detail about details of antimicrobials, the reasons for development of antimicrobial resistance, how we can prevent antimicrobial resistance, how to interpret the sensitivity reports of microbiology, what are the essentials of antibiogram and antibiotic policy, what are the principles of antibiotic therapy, what are the surveillance and strategies for antimicrobial stewardship, the core elements of antimicrobial stewardship, what is the role of team in compliance towards antimicrobial stewardship, the key performance indicators of antimicrobial stewardship, and finally, we will summarize. Let us first, before we move towards the details, let us first understand the difference between antimicrobials and antibiotics. Antimicrobials is a broader terminology, includes sulfonamides and many other substances not falling under the definitions of antibiotic, but have similar application. While antibiotics is a chemical substance produced by various species of microorganisms, bacteria, fungi, and other organisms that can destroy or inhibit the microorganisms. So antibiotics can be classified by several ways on the basis of chemical structures, the mechanism of actions, the spectrum of activity, and the mode of action. Let us see in details about the classification. On the basis of mechanism of action, antibiotics are classified as follows. There are cell wall synthesis inhibitors of antibiotics, which includes antibiotics like penicillins, cephalosporins, and vancomycins, which have their actions on the basis of inhibition of the cell wall synthesis. While there are inhibitors of beta-lactamases. Beta-lactamase is an enzyme that is released by the bacteria against the beta-lactam group of antibiotics. Now, beta-lactam group of antibiotics have a beta-lactam ring. To inactivate the antibiotic, these enzymes are released by the bacteria called as beta-lactamase enzymes. So some of the antibiotics have actions against this beta-lactamase, and they are called as beta-lactamase inhibitors, and these antibiotics include polymyxin and bezitracin. While there are protein synthesis inhibitors, like some of the antibiotics act on the 30S subunit of the ribosomes, some act on the 50S subunit of the ribosomes, as listed below. Aminoglycosides and gentamicin acts on the 30S, macrolides and chloramphenicol acts on the 50S. So these are the antibiotics which inhibits the protein synthesis and thereby inhibits or kills the growth of bacteria. Then there are antibiotics that inhibits the DNA synthesis, which includes fluoroquinolones, quinolones, ciprofloxacin, and metronidazole. There are antibiotics which inhibit the RNA synthesis, which includes rifampin, And there are antibiotics which includes mycolic acid synthesis, which includes isoniazid. There are folic acid synthesis inhibitors, which includes sulfonamide and trimethoprim. So this is how on the basis of mechanism of action the antibiotics are classified. As you can see from this picture, the inhibition on the basis of inhibition of cell wall synthesis, there are antibiotics like penicillin, vancomycin, cephalosporins. Then on cell membrane function, there are antibiotics like polymyxin. Then on protein synthesis, there are antibiotics like tetracycline, erythromycin, and others, as we have seen before in the previous slide. On the basis of action of the antimicrobials, there are antibiotics like isoniazid, which are exclusively active against mycobacteria, or there are antibiotics like tetracyclines, which is a broad spectrum antibiotic, which is active against the rickettsia, chlamydia, gram-positive, gram-negative bacteria, while isoniazid is a narrow spectrum antibiotic restricted to only mycobacteria. So, while streptomycin is restricted to only mycobacterium and gram-negative bacteria. So, on the basis of spectrum of action, these are either a narrow spectrum or broad spectrum activity action antimicrobials. On the basis of mode of action, it can be either bacteriostatic antibiotic or bactericidal antibiotic. Bacteriostatic antibiotic that inhibits the growth of bacteria, while bactericidal antibiotic that directly kills the bacteria. So bacteriostatic antibiotics includes antibiotics like tetracyclines, chloramphenicol, erythromycin, while bactericidal includes antibiotics like cephalosporins, penicillins, aminoglycosides. On the basis of location and severity of the infection, this also affects the choices of antibiotics. For example, CNS infection calls for a bactericidal treatment. For the CNS infection, the drug of choice or the empirical therapy of choice will be towards bactericidal antibiotics. Now, antibiotics should be used only if a clinical means if the patient clinical conditions demand for the antibiotic treatment, then only the antibiotics should be used, or there is a laboratory evidence in form of culture and sensitivity reports, then only antibiotics should be used. Certain bacterial infections like abscesses, infection with some foreign bodies require surgical interventions, and they usually don't respond to antibiotic alone. They are usually combined with the surgery, and antibiotics usually are combined for such bacterial infections like abscesses or foreign body infections. Culture and sensitivity testings are also essential. And actually, it's the most important thing for a compliance to the antimicrobial stewardship. Culture and sensitivity reports testings is the basis for running stewardship program. So culture and sensitivity testing are essential for selecting a drug for serious infection. However, the treatment must often begin before culture results are available. Culture results can be used for de-escalation or for switching of antibiotics or from IV to oral and other such interventions. So treatments must begin before culture results based on the local antibiogram and necessitating the selection according to the most likely pathogens. Unfortunately, as we know about antimicrobial usage and the local antibiogram, still there is an irrational use which is leading to antimicrobial resistance. Antimicrobial resistance is now rightly called as the silent killer pandemic going on, and India is often in the news for being the buster of drug-resistant pathogens like MRSA, VRE, CRE, and others. What is the cause of such irrational use of antibiotics, especially in such developing countries like in India? The issues like poor medical records. Poor medical records is one issue because we don't have the clinician doesn't have the clear, complete information for the diagnosis and the antimicrobial therapy of the patients. So poor medical records, lack of patient education about illness and treatment, then indiscriminate usage of antibiotics, most of the time for viral causes or for fevers of unknown origins. Antibiotics are indiscriminately used. Antibiotics are also prescribed for some metabolic disorders like rheumatoid arthritis and others. Inadequate dosage, then inadequate duration, inadequate frequency, improper timing, or other causes that is leading to irrational usage of antibiotics. Then self-medication for the patients also is another important, is one of the leading cause for irrational usage of antibiotics. Lack of standard treatment guidelines is another factor. Now, in the year 2016, we had a release of national antibiotic policy. Again, in the current year, it is being released. So we can refer to the same treatment and standard treatment guidelines for the prescription of antimicrobials. Then lack of continuing medical education. There are very few courses presently going on antimicrobial stewardship or towards antimicrobial resistance. It is not also included under the curriculum. And antimicrobial resistance or stewardship or infection control are not in detail included under the curriculum of the undergraduate or the postgraduate courses. So also there is a lack of continuing medical education or workshops or conferences for towards the same. So it's continuing medical education is a need, and the lack of the same is leading towards the irrational use. Then promotion to pharmaceutical industry is open secret. That is the promotion or by the pharmaceutical about antibiotics is also leading to an irrational usage. And treatment of viral infections like common cold, flu, and other viral upper respiratory infections, diarrhea, and another common causes for misuse of antibiotics, subtherapeutic dosage and duration, like 3 tablets of metronidazole, 1 worst strip of amoxicillin. There's such practices like which leads to subtherapeutic dosage and duration, which is leading to the antibiotic misuse and hence the antimicrobial resistance. Then, as we everyone know, all of you might be aware, gentamicin and amikacin are also effective for some infection, for some indication in a higher dose. And use of for such indication, if gentamicin or amikacin is used in a lower dose, it leads to the resistance. Also, if you have a microbiology lab and you see the lab reports, most of the time gentamicin and amikacin are reported into low dose concentrations. It is advised to the clinician to ask to the microbiologist for a high dose concentration of gentamicin and amikacin testings. What are the other common reasons for misuse? Development of resistance, the treatment failure, the prolonged illness or the morbidity, or the increased cost of the patients, and the higher death rate are the results of such antibiotic misuses. Curable diseases such as diseases from sore throat and ear infections are moving towards to TB and malaria are in danger of becoming incurable because of such serious pandemic of antimicrobial resistance. A new report warns that increasing drug resistance could rob the world of its opportunity of curing illnesses and stop the epidemics. WHO in 2017 rated the multi-drug resistance, the multi-drug resistance in the gram-negative bacteria as a critical and the highest priority pathogen ranks. Alexander Fleming, when he had discovered penicillin, had passed a note in the New York Times. As time passes, resistance will develop to penicillin, and as we have seen, within 5 to 10 years of the development of the discovery of the antibiotics, resistance has developed. Some of the antibiotics have noted the resistance. We have observed resistance within 2 to 3 years of its discovery. Poor antibiotic means survival resistant bacteria. Resistant bacteria accumulates and spreads, and the clinical complication increases because of such resistant bacteria, and which lengthens the hospital stays and adds to the cost. It is a major concern, especially in ICU settings. As we see the number of days in hospital, as we can see from this present slide, the number of days in a regular wards or clinical settings is about 30%, but in case of resistance in ICU, it moves towards 80%. So the resistance is a serious concern in high-risk areas such as in ICU. So what does resistance means? People cannot be effectively treated. People are ill longer. People are at greater risk of dying. There is a high chances of morbidity, mortality. There is a higher risk of hospital-acquired infections. And epidemics gets prolonged, epidemics, especially to be very specific, of antimicrobial resistance. Now, resistance due to misuse is because of the rise in the antibiotic sales in the hospital sectors. We are as a part of the strategy of antimicrobial stewardship, often monitor the consumption of antibiotics, because this consumption or the rise in the antibiotic sales has been led to the misuse of antibiotics, leading to resistance thereby. Then self-medication, as said before, sales promotion schemes provided by pharmaceutical manufacturers as well as OD, or the counter availability of the antibiotics or antimicrobials are leading to self-medication, hence the indiscriminate use and hence the antimicrobial resistance. Then poor health control measures like poor isolation precautions or hand hygiene or transmission-based precautions are leading to the transmission of this resistant pathogens too. Then poor immunization coverage, that is vaccination, especially like against when there are vaccines available against few infections and there is poor immunization coverage, it's another cause serious concern leading to towards the resistance. Then there are other factors like health system factors wherein there is improper diagnosis that is leading to the irrational usage. Especially the practice by the healthcare professional in ICU settings like intensive care unit. It is an area in the hospital where the resistant problems are developed due to the misuse of multiple antibiotics for a longer period of time. So special attention should be taken in ICU, wherein such broad spectrum or higher antibiotics are prescribed, which is a potential for leading to antimicrobial resistance. Industries and scale-up plant like disposing the antimicrobial waste directly into the natural water resource is also leading to development of resistance in the bacteria. And it's a concept called as One Health. Disposing of the antimicrobial waste into the water and the food resources and it's indiscriminate in agriculture and animal husbandry is also raising towards antimicrobial resistance. And hence the concept of One Health, that the stewardship needs to be followed in all sectors as well as hospital, agriculture, and animal husbandry if you want to prevent antimicrobial resistance. Personal hygiene products is another risk factor. Means we are very indiscriminate using the personal hygiene products, which provides a need for the microbes in the environment to alter the ecology of the environment by raising the ratio of the resistance to the susceptible organisms. Agriculture use, as I said before, the practice of using these antimicrobials, both the developed and developing nations, the 90% of antibiotics are most of the times leading to resistance are given to the animals. This, of course, in poultry or in meat and meat industry, wherein the antimicrobial resistance pathogens are transmitted to humans via the food chain. Now, what is the date? Let's see before we move to the details. What's the date attributable to antimicrobial resistance every year? It is projected presently. It is estimated that about as we can see from the present chart, around 7 lakhs of the estimates per year is because of dates are because of antimicrobial resistance presently, which will move towards 10 million by the year 2050. While it will, while you can see from the chart, it will cross the same numbers of cancer, cholera, diabetes, non-communicable diseases, diarrheal diseases, measles, and road traffic accidents and tetanus. So it will be like a pandemic that it's a pandemic that is going on, but it will burst by the year 2050, which will be wherein the number of deaths will move towards 10 million per year. So it's a serious, it's a high time we control this issue of pandemic of antimicrobial resistance. There's the impact on the current and the future patients too. Antibiotic usage contributes to development of antimicrobial resistance. For most medicine, side effects are limited to individual patient, but the resistance developed from exposure to an antibiotic may affect the patient, but also affect the future patients if the infection control measures are not followed. We'll see in details of the same in the next slides. What is the report of antimicrobial resistance in India? How much is the consumption of antimicrobials? Let's see see this data. We monitor in hospital settings the antimicrobial consumption in terms of defined daily doses per 1,000 inpatient admissions. And it has been seen from the study that as we move from the year 2000 to 2015, the consumption of cephalosporins has increased tremendously, as we can see from this chart. The consumption of cephalosporin, especially for the empirical basis, cephalosporins are the drug of choice, and its consumption is increased. Now the concern is about the fluoroquinolones also. The resistance has developed against the fluoroquinolones, and however, we are seeing a dip in the uses of the same. So similar dip we are expecting in the broad spectrum penicillins and tetracyclines, wherein we are seeing an increase in the consumption in Indian settings. So it is advised to the healthcare settings, to stakeholders to monitor the consumption of this formula of this at least the high risk antibiotics or the result of the resistant antibiotics. Monitor the usage and see, do a root cause analysis why there is an increase or decrease towards the consumption, and have it preventive and corrective measures for the same. And what are the origins of resistance? It can be either natural resistance or also called as intrinsic resistance or acquired resistance. What is intrinsic resistance? Is a large number of bacteria Both commensals as well as pathogens are naturally tend to be resistant to certain classes of antimicrobials. As we can see from the chart, some bacteria like bacteriates, which are anaerobes, are intrinsically resistant against aminoglycosides. All the gram-positives are intrinsically resistant against H2-num. Enterococci, which is a deadly nosocomial pathogen or hospital-acquired pathogen, is intrinsically or natural resistance against a huge group of antibiotics like aminoglycosides, salicylates, cephalosporins, macrolides, and others, which are the most, as we have seen from the previous slide, cephalosporins are the most commonly prescribed antibiotic. And if the patient, and if the incidence of enterococci is high in the healthcare settings, this intrinsic resistance may lead to high chances of morbidity and mortality. So the natural resistance needs to be taken into account while prescribing the antimicrobials. The microbiologist in that healthcare setting should mention this note of this natural resistance in the reports for the guidance of the clinicians. Other examples include the listeria, which is less isolated, which is natural resistance against cephalosporins. E. coli is natural resistance against macrolides. Klebsiella, which is a commonly occurring pathogens, is resistant against ampicillin. Serraceae against macrolides. Pseudomonas against first and second generation cephalosporins. Tetracyclines. Similarly for protease, tetracyclines natural resistance. And other such examples of antimicrobials, which are natural resistance by some pathogens, needs to be considered while prescribing antimicrobials. Acquired resistance, let us about the natural resistance. If we see the acquired resistance may be because of the decreased influx or increased efflux. Influx means the entry of the antibiotics into the bacterial cell, or increased efflux, that is pumping out the antibiotics from the bacterial cell. Because of increased efflux or decreased influx, there might be a resistance against the antibiotics. And then then inactivation of drug by some enzymes or modification of the cell membranes can lead to resistance against antibiotics. What we should be worried about? The urgent threats includes carbapenem-resistant Acinetobacter. Then Candida auris. In the COVID times, we had outbreaks in most of the healthcare settings about Candida auris, which is intrinsic resistance against most of the antifungals, except the echinocandidates like Micafungin and Caspofungin, wherein is also which are bacteriostatic against Candida auris. So Candida auris is a deadly hospital-acquired pathogen and is an urgent threat, followed by Clostridium difficile and drug-resistant Neisseria gonorrhea. While the serious threats includes the drug-resistant Cyanobacter, the drug-resistant Candida, the ESBL, that is the extended spectrum beta-lactamase producing Enterobacteria, which are resistant against the cephalosporins. Then vancomycin resistance Enterococci, MLT drug-resistant Pseudomonobacter, drugs-resistant Shigella, drug-resistant tuberculosis, and others. Now let us understand about multi-drug resistant organisms. Multi-drug resistant organisms are bacteria that have developed resistance to at least one agent in 3 or more classes of antimicrobials. These antibiotics can no longer be used effectively to control or kill the bacteria. MDROs are predominantly bacteria, but it can be viruses, fungi, or parasites. The name of some MDROs identify resistance to only one drug. For example, MRSA. MRSA stands for methicillin resistant Staphylococcus aureus. However, when MRSA is isolated from the patient sample, it indicates resistance against the beta-lactam group of antibiotics like penicillins, cephalosporins, carbapenems, and monobactams like H2-num. So we'll share the details about the MRSA herein. MRSA was first isolated in the United States in 1968, but by the year 1990s and moving towards 2000 and 2003, nearly it's the data that is present slide shows about USA, but I will share this data in Indian settings. Nearly 30% of the gram-positive bacteria isolated are about Staphylococcus aureus, and nearly 30 to 50% of the Staphylococcus aureus isolated in Indian settings are methicillin-resistant Staphylococcus aureus. The MRSA is a very serious concern, serious issue, and it's a high time that we have policies and protocols in healthcare settings to deal with this MRSA. So this is how the incidence of MRSA in intensive care units. The current chart shows the incidence from the in the span of 10 years, and from 95 to 2004, where there is a high increase in the MRSA, and it has significantly increased in the last 10 years too. That is about MRSA. It is advised to the healthcare settings to have protocols and policies against MRSA. We can screen. We can have a protocol in place, like having screening the high risk patients, like immunosuppressed patients or patients who are on immunosuppressive therapy. To screen for MRSA, who are more susceptible to MRSA infection or MDRO infections, and have decontaminate those patients from MRSA. Have contact precautions in place for such infected or colonized patients to prevent the spread. Let us move towards the other MDRO, that is a vancomycin resistant enterococcus. It can be either Enterococcus faecalis or Piscium or Enterococcus species unspecified that is resistant to vancomycin by standard manual detection method or by direct by PCR molecular method. It includes resistance to, as said before, penicillin, cephalosporins, monobactums, carbapenems, and vancomycin. The treatment of such as VRE is linezolid. Vancomycin, the incidence of VRE is also increasing in the last 2 decades, and the treatment choice only being linezolid is oftenly is isolated from nosocomial areas like from OT areas, from the bedsides, rails to and other such high touch surfaces of the healthcare settings. Then the other MDRO is a carbapenem resistant Enterobacteria, which includes any E. coli, Klebsiella species or Enterobacter species, which is testing resistant to either imipenem or meropenem or doropenem, either of this carbapenems by standard AST methods or by production of or by detection by carbapenemous enzymes like KPC, IMP, VIM, NDM, oxo-48 and others. So isolation of a CRE or the detection of such resistant enzymes of carbapenems indicates resistance to imipenem, meropenem, doropenem, or ertapenem. And a treatment of choice for this CRE is ceftazidime, ivectum, aminoglycosides like gentamicin, amikacin, colistin, tigecycline, and fosfomycin. Carbapenem retail sales, as we had said before in the previous slides, the consumption is a serious concern, and the retail sales of carbapenems in the selected countries from if you see from the present chart, wherein USA, Brazil, and India, and Pakistan, and Egypt have been compared, is the consumption of carbapenems is high, very high in developing countries like India, and Pakistan, and Egypt. Let's move to the other MDRO, that is extended spectrum beta-lactamase. Guess how much will be the prevalence of ESBL? It's too very high. It's about 80 to 90% is the prevalence of ESBLs, while the prevalence of CRE is moving across at 50%. So it's a serious concern. ESBL prevalence is about 80 to 90%. These are the bacterial enzymes capable of hydrolyzing the beta-lactam ring and then conferring resistance to all penicillins, first and second and third generation cephalosporins, and also moving towards the first generation cephalosporins and acetona. The resistance to how it is detected? What is the screening criteria? Resistant to ceftriaxone and cefotaxime. Now, the present CLSI breakpoints, if we see the resistance to either one of the cephalosporin, it indicates it is a screen. It indicates that it is an ESBL producing organism. So there is no separate testing for ESBL is presently required if the present recent CLSI breakpoints are being used to interpret the sensitivity reports. The treatment of choice for ESBL includes carbapenems and beta-lactam group of antibiotics like peptides and ceftazidime and others. If you see this scattered diagram, when in areas where the sanitation access is less, the prevalence, the incidence of this ESBL percentage is too high. When there is sanitation access is very less. When the sanitation access is very high, the ESBL prevalence is too low. So this is how there is a correlation between the ESBL percentage prevalence and the sanitation access. So sanitation, the environmental cleaning in the healthcare settings needs to be stringently followed if you want to prevent the incidence or occurrence of ESBLs and other such MDROs. We have seen the urgent threat and the serious threat. What are the concerning threats is the erythromycin-resistant group A streptococcus or clindamycin-resistant group B streptococcus. And under the watch list is the azole-resistant as per the fumigators, drug-resistant mycoplasma, drug-resistant bordetella. WHO has released the list of world's most dangerous superbugs. Recently, it has released the list of the for the fungi also. The priority one critical pathogens to be considered for rational to be considered to be special attention needs is includes Acinetobacter baumannii, which is carbapenem resistance, or Pseudomonas aeruginosa, which is carbapenem resistant, or Enterobacter, which is carbapenem resistant. The other priority two includes Enterococcus, Staphylococcus, Campylobacter, Salmonella, and others. While the priority three, that is medium, includes Streptococcus, Haemophilus shigella, which is fluoroquinone resistant. Now let us see the habitats and reservoirs of antibiotic resistant gram-negative bacilli. We have seen about the details of the antibiotics, let us see the details about the gram-negative, this MDROs. Say for example, take a Klebsiella species. The natural reservoirs and site of colonization of Klebsiella includes gastrointestinal and respiratory tract of humans and animals. And then fruits, vegetables, wood pulp, surface waters, and sinks and drainages. How does it get transmitted from such environmental surfaces or for the colonized areas? It gets transmitted by contact route, either by hands to hands or by through equipment or by ingestion of contaminated food and water or bathing or aerosol droplets. That are the transmission parts of Klebsiella species. What it leads to? It leads to sepsis, UTI, pneumonia, meningitis, other ocular infections. So Klebsiella, this was about the reservoir of or site of colonization of Klebsiella. How does it transmit and what is cause? Similarly, for the other enterobacteria like E. coli and others, lower GI tract of humans and animals, plants, dairy products are the sites of colonization and reservoirs. It's supposed to, like Klebsiella, it's supposed to contact route by direct or indirect or to contaminate food and water, leading to UTI, GI infections, and intra-abdominal infections. If you see Acinetobacter species, it's the reservoir of Acinetobacter are the human skin and mucous membranes of animals, vegetables, fish, wastewater treatment plants, warm and humid environments, which are the sites of colonization or reservoirs for Acinetobacter species. It also spreads by contact route or ingestion and through inhalation of droplets. It's a deadly pathogen. It leads to respiratory infection in any organ system. It leads to respiratory infection, soft tissue infection, pancreatitis, and septic arteritis too. Other MDRO is the Pseudomonas aeruginosa, which is the colonization or reservoir of sites of Pseudomonas aeruginosa is the human skin, the upper respiratory system, especially in the case of cystic fibrosis, then in GI tract, the raw milk, other reservoirs of Pseudomonas aeruginosa. It also spreads to contact route or injection or inhalation, and usually do not cause infection in healthy people, but in immunosuppressed, it is very little, and it can lead to sepsis and acute and chronic lung infections. Now, inside the hospitals, this MD multidisciplinary organ can be where there can be lurking. It can be lurking in the colonized patients. It can be lurking in the biofilms. Biofilms is another serious concern, especially in the long stay patients or patients who are on longer stay, who are in tubings and catheters and other such invasive devices. Biofilms biofilms develops which against which the antibiotics are less or effective against the biofilms. And then hospital linens, then keyboards, other high touch surfaces like keyboards or tube and bed rails, doors, endoscopes, toilet rooms, hand wash basins, and other areas of the hospital where these MDROs can be frequently be lurking. So what do you educate to the patients, to the community? Antibiotic resistance, what you can do? Antibiotic resistance happens when bacteria change and become resistant to antibiotics used to treat the infection they cause. So only use the antibiotics when prescribed by certified healthcare professional. Always take the full prescription, even if you feel better. Complete the dose of the antimicrobials. We'll see in the details about this instruction in the next slides as we move ahead. Then never use leftover antibiotics. It's often a practice in the community that leftover antibiotics get self-medicated. Then never share the antibiotics with others. And then this has to be instructed to the patients and prevent the infections by etiquettes like personal etiquettes, hygiene etiquettes like washing the hands, avoiding contact with sick people, and keeping the vaccinations up to date. Let us see this cycle of antimicrobial resistance and how wherein we can put our interventions to prevent the infections. When the pathogens causes an infection, we have an antimicrobial usage therein, and if it is not inappropriate, if it is not appropriate, then it leads to resistance. However, if it is a susceptible pathogen, what our intervention will be prevent the infection. Preventing infection is the first step to develop to prevent and control the antimicrobial resistance. So prevention of infection can be done by simple measures like hand hygiene or contact or transmission based precautions like contact precautions, droplet precautions, or airborne precautions, or standard precautions. So preventing infection, I repeat again, is will be the first measure to prevent the antimicrobial resistance before we move towards the effective diagnosis and treatment. After if the patient gets infection, effective diagnosis and treatment is another intervention that we can do to prevent the resistance. We'll speak about this effective diagnosis and treatment in the next slides. Then our antimicrobial resistance, it should be optimally used according to the right dosage, duration, and frequency to prevent resistance. And if there is an antimicrobial resistance MDR infection in the patient, resistant pathogen, then it needs to be prevented by its transmission by following transmission-based precautions like contact, airborne, droplet, and standard precautions. What are the preventive strategies? Curtail the production, prescription, and consumption of antibiotics. Have its monitoring is in healthcare settings. Monitor the antimicrobial consumption in terms of defined daily doses. Do to follow all the formulary antibiotics. It will be better if you categorize. If you do it very specifically for the aware list of antibiotics, like for the watch list, for the essential watch list, for the access list, for the restricted list. Monitor the consumption and see where we see the up and downs, and do the RC and kappa for the same. Then education of the general population and the healthcare professionals, the veterinarians and pharmacists about the means and prevention, about the means of prevention and proper therapy of infections. Offering access to clean, affordable water and sanitation is another important measure. It can help to prevent the transmission of the drug-resistant pathogen. Promoting vaccination is another important measure. Now, what are the reservoir and transmission strategies in healthcare and long-term facilities? Implement a mandatory stewardship program. Now, we'll be seeing the stewardship program, the components and strategies in next slides. It's necessary to, and as also the NABH, which is an accrediting body in India, have made it mandatory for every healthcare setting for NABH accreditation to have a stewardship program in place in implementation. Implement a stewardship program in healthcare setting, have the surveillance, recording, reporting, evaluating the multi-drug resistant pathogens, have a patient history and risk-based screening should be done, assess the travel history, the screening of the high-risk patients like immunosuppressed patients, implement contact precautions if there is susceptible, if there is a risk of drug-resistant pathogens, assess the medical history, the stay within the last 12 months, training and education of the personnel responsible for screening should be done. Principle of rapid diagnosis or quick transmission of information, quick treatment is another strategy. So there are many other rapid diagnostic methods like there are genotypic methods or molecular methods like carbapenem resistance or biofire, wherein we detect the pathogens within an hour of the blood culture for flagging. So there's such rapid diagnosis methods can be used for the quick transmission of information to the clinicians for the quickest treatment. Then monitor and reinforce infection control standard precautions. So if you want to prevent the antimicrobial resistance, the first step, as I said before, have infection control standard precautions in place, stringently followed. Then additional transmission-based precautions like contact precautions to be more stringently be followed to prevent the colonization of the patients by multi-resistant organisms. Then safe decontamination practices and cleaning protocols. It's often said that hand hygiene is important, but I say environmental hygiene is equally important, and environmental hygiene should be stringently followed by safe decontamination, sterilization, disinfection practices, and cleaning protocols. So that was about the antimicrobials, the bacteria, and the preventive strategies. But I have been a project lead for across 11 hospitals, and I have been observing many healthcare settings. But I think, in my opinion, that the behavior change or is important is an important area to be focused and to be studied and to be improved if you want to prevent the antimicrobial resistance. It comes under the strategy of the antimicrobial stewardship to have improvement towards the knowledge, attitudes, practices, the processes, the identity of the problem, and the outcomes of the problem solutions. So the 3 layers of the behavioral change needs to be focused, needs to be improved along with the technical considerations of antimicrobial resistance. Spread this awareness of antimicrobial resistance and stop this resistance. Always get advice from healthcare workers. That's the instruction to be given to the patients and the community. Now I will move towards this in detail about the testing, antimicrobial susceptibility testing. It's often clinicians take the guidance of the microbiologist, and often there is a queries about interpreting the susceptibility testing. So in quickly, I will present how to interpret the sensitive testings. Now, first of, it's the basis for running the stewardship program to prevent antimicrobial resistance. Why we do sensitive testing? It's for the selection of the appropriate treatment, then monitor the development of resistance. From MRSA, ESBL, VRE, we get to know how much is the resistance incidence and prevalence, and accordingly we put our interventions for the same. Then we compare, when sensitive testing gives us the resistance pattern of the hospital across different organisms, across different areas, and across different clinical samples like respiratory samples, urine samples, blood samples. So we can develop an antibiogram from the same report, and we can compare this local our antibiogram with antibiograms of other healthcare settings across different geographical areas and facilities. So this sensitive reports help us to compare the trends and to develop and evaluate the interventions for the stewardships. That was about the sensitive testing. The most important is, now I said before, sensitive testing reports form the basis for running the stewardship program. But for the sensitive testing, correct sampling or appropriate or right sampling is most important. Say for example, when you take a blood sample, in most of the settings that's been observed, it's a single bottle of aerobic bottle that's been sent for culture. However, the guidelines says, the practices says, for standard practices recommends that a paired blood culture bottles, that is a aerobic and anaerobic bottle from a single prick, say from the left hand, and a set of paired aerobic and anaerobic bottles from the next hand, that is the right hand, should be taken always while for blood cultures for diagnosis of sepsis, and it should be done at the right time, that is just before the spike of fever or at the spike of fever. And the blood culture and it is my observation I have seen. It's everyone knows here that more than 80% of the organisms isolated in healthcare settings are faculty to anaerobes. We don't say the faculty aerobe, but we say the faculty anaerobes. While we missing sending the samples for culture, we send the aerobic bottle. So I have what observed, anaerobic bottle from the machines like Bactec and Bactec. Anaerobic bottle is the first to flag before the aerobic bottle. Sometimes I have seen that aerobic bottle doesn't flag. So the anaerobic bottle should always be paired with an aerobic bottle for blood culture. And blood culture bottle should be kept at room temperature. It should not be refrigerated. Similarly, for the CSF sample, the CSF sample should not be refrigerated. And the sample, whether it's a blood sample or a CSF sample, which are precious samples, but other samples too, like stool samples or urine samples, this should be immediately sent to the lab for cultures, ideally within 2 hours of collection from the
within 1 hour. Yeah, with that.
Ideally, the blood sample should be processed in the back to the lab within 2 hours of collection. Then let's say about the testing types. Here I missed here. CSF sample, as soon as the CSF sample, it has been, if you see from the previous textbooks of microbiology and from the clinical textbook, CSF, there was a practice before that CSF sample used to be immediately inoculated into warmed chocolate agar plates. The chocolate agar plate is a culture plate that is used in a microbiology laboratory. It was a practice for isolation of these fastidious organisms like Neisseria, Streptococcus, or Haemophilus influenza. The CSF, the clinician used to immediately, or the microbiologist was to be called, and the CSF was to be immediately inoculated on this warm chocolate agar pads. However, now the practice has been replaced by that the CSF sample is immediately inoculated into fluid culture bottles, like we have separate fluid bottles of Bactec and Bactec Alert. The CSF it's recommended or advised to that the CSF sample should be immediately inoculated in such fluid culture bottles, which is available presently. However, still it's been seen that series of sample in a sterile bottle, sterile container is sent to the microbial lab, and by the time it reaches the microbial lab and gets processed, it is already 8 hours over. And hence there is a no growth, and which is often complained by the clinicians that there is no growth that's being reported from the series sample. So for the proper rise, for the, if it is suspected and for increasing the yield from the series of samples, it should be processed within. It should be immediately inoculated into food culture bottles and immediately be loaded into the machines. So there are phenotypic methods available like herbivore diffusion method, and there are genotypic methods also available. Genotypic methods are very rapid. Within an hour, we get the identification of the organism, also the resistance mechanism. However, the negativity in a genotypic method like PCR or a gene expert machine, the negativity does not necessarily mean there is a susceptibility. Also, the positivity does not necessarily mean there is a resistance, because there might be an that there might be a gene or the enzyme that is present in the bacteria, but in the sample, but it might not be that it has expressed this resistance. So that's one of the limitation of genotypic methods, and also it is limited to some antibiotics only. Hence, the most commonly practiced method is the phenotypic method, that is carbon diffusion or the broad dilution method, wherein they are universally applicable, they are mechanism independent and has a therapeutic relevance. However, the the limitation with this phenotypic method is that it requires time about 24 to 36 hours, especially for the fast stage, it takes 48 hours for the microbial growth. Just we'll share here in how what is the manual diffusion method that has been done. Here we inoculate in a culture plate, we inoculate the bacterial suspension, we prepare a lawn culture, and over it we inoculate the antibiotic discs. And after the overnight incubation, we measure the clear zones. And based on the clear zones, the diameter of the clear zones, which is measured by scale, we interpret it as a sensitive resistance. So that was about the herbivore manual disc diffusion method. Other method is the MIC method, wherein in a well wherein there is an increasing concentration of antibiotic, the bacterial suspensions are inoculated, and overnight it is incubated, and the next day it is observed for the concentration of the well that inhibits or there's a clear, there is no bacterial growth, and that is taken as the MIC, or also the full form of MIC as a minimum inhibitor concentration. As we can see from this slide, this well is showing no growth or no clear, there is no turbidity, and hence the MIC of 1 is taken as the MIC for that bacteria against that antibiotic. So we have such ways against each antibiotic for that particular organism, and we interpret the clear zones, clear well as the MIC. That was about the disc diffusion. That was about the broad dilution. Other method is the E-test or the epsilometer test, wherein there is a antimicrobial strip with the graded concentration of the antibiotics, which is inoculated into culture plates, and then after overnight incubation, it like the disc method, the zones of clearing are interpreted for the sensitivity or resistant results. The other thing is microbiology instruments, automated instruments like Biotech, Phoenix. The principle is like the similar that the MIC broad dilution, broad macro dilution is the principle for these microbiology instruments. We have Phoenix from BD, we have from Bacteria, Biotech from Bacteria Alert. The advantage of this method that the single card provides there is a sensitive pattern across different antibiotics for the organism as per the CLSI guidelines. It's also the other advantage is that there are less chances of errors, and it's also it gives a real-time antibiogram. There are software attached to these machines which gives a real-time antibiogram across different antibiotics, across different clinical samples, and if the data entry is done complete, it gives an antibiogram across different clinical areas also. So that was about the manual disc diffusion method, the broad dilution method, the E-test, and the automated microbiology system. However, the gold standard among these methods is the broad dilution. Especially we see for some antibiotics like colistin or polymyxin, it is recommended it should be done only by broad dilution method. Or there is other method called as agar dilution, similarly like broad dilution. We have agar dilution, where antibodies like aztreonam is to be recombinant to be done by only by agar dilution. So from studies, it has been observed for and according to antibiotic needs, the methods changes. So let us see how to interpret. We have seen that we get a MIC from broad dilution method or for the E-test method. For every MIC, we have breakpoints. There is a well-established system of interpreting these MICs according to breakpoints of antibiotics. Breakpoints help to categorize this MIC either as resistant or susceptible. If a particular MIC is lesser than the breakpoint, if a particular MIC is lesser than the breakpoint, it is interpreted as susceptible. If a particular MIC is more than the breakpoint, it is interpreted as resistant. Susceptible, resistant, intermediate, or if the particular MIC is between the sensitive and resistant breakpoint, it is interpreted as intermediate. Let me just clear out here what we understand by susceptible, resistant, intermediate. Susceptible MIC means the patient organism will respond to the therapy with an antibiotic using the doses recommended for that infection. While the resistant indicates that the organism will not be inhibited or by the dosage normally used. While the intermediate indicates that clinical response is likely to be less than the susceptible, but possible at a higher dosage. So let's see about the breakpoints. Breakpoints have been studied on the basis of the serum achievable levels of antimicrobial agents, the particular resistance mechanisms, and the therapeutic outcomes. Often we see that in the microbiology reports, when the MICs are released on the reports and interpreted as either sensitive or resistant. However, the clinician, it is advised to the clinician to consider the breakpoints too while interpreting the MICs. It offers some of the recent microbiology have also been attaching the breakpoints along with the microbiology reports, or they are mentioning the efficacy ratio or the therapeutic index or the therapeutic therapeutic index and the quotient. How the breakpoints are determined? They are determined by the first step includes determine the epidemiologic cutoff. And the second step includes application of pharmacokinetics and pharmacodynamics to the epidemiologic cutoff. And thirdly, by the clinical correlations, clinical studies, the breakpoints are determined using the above two steps results. Now, let us see about the epidemiological cutoff. Now, when the breakpoints are not available, for example, for Shigella, Salmonella, the azithromycin breakpoints are not available. Just an example, for such a, or for the Canada auris, they make for antifungals, the breakpoints are not available. In such cases, epidemiological cutoff values should be taken for guidance. Now, epidemiological cutoff, what it does, it has divided the MIC concentration. As you can see from the slide, the MIC concentration into either wild type and non-wild type. When the MICs which are very lesser, the lower MICs are wild type wild type of ECOF, wherein there is no resistance mechanism. While the non-wild type includes ECOFs of MICs where there is a resistance mechanism. So epidemiological cutoff only help us whether there is whether the organism is a wild type or a non-wild type. So wild type, no resistance mechanism, while a non-wild type, there is a resistance mechanism. Non-wild type are organism with a higher MICs, while wild type with a lower MICs. It's a reverse for breakpoints, wherein we get with the higher the disc diameters, they are wild type, with the lower disc diameters, it is non-wild type. So the epidemiological cutoff values should be taken into consideration if there are no breakpoints, for example, like Shigella or Salmonella for against azithromycin. So that was about the sensitive testings and its the value and the importance of ECOFs and how to interpret the sensitive reports. Let us see about the antibiogram. Most of the healthcare settings, we see that the antibiogram is outdated, means it's prepared 5 to 10 years back, and it's being not readily available for the clinical. Antibiograms every every healthcare setting should have their local antibiogram. What is an antibiogram? It is a representation in a single slide or a single paper, the sensitivity patterns across different antibiograms, across different clinical samples, across different clinical areas, the sensitivity pattern of the microorganisms against different antibiotics. How antibiotics are, what is the importance? So it shows the significance of changes in the percentage or the incidence of prevalence of susceptible isolates. For an antibiogram to be prepared, the organisms, the culture should be more than 30 isolates should be taken into consideration. So 30 reports should be taken into consideration, or 6 months samples should be taken into consideration while preparing the antibiogram for a healthcare setting. And include only the first isolate, do not include the second isolate. Stratify this antibiogram as according to if there are MDROs, then mention it separately in the antibiogram like MRSA, VRE, CRE, or ESB. Antibiogram helps to compare the local antibiogram with the other antibiogram with other healthcare settings across different geographical areas. Ensure the antibiogram is correctly made, the quality is maintained. Compile the report of antibiogram and train annually. Have it revised the antibiogram on an annual basis. Change the empirical therapy on the basis of changes in the those in the antibiograms accordingly. So this is how the antibiogram looks. This is the thing. It is a half of the half page of the antibiogram that I'm showing in the slide, wherein we get the frequency in the antibiogram, the frequency of the infected organisms isolated from different clinical samples. Like because we can see the different organisms in a percentage isolated from blood culture, a different organism isolated percentage from urine, similarly from pus and tracheal cultures. Then the next part is the sensitivity of this organism, commonly isolated organisms against different antibiotics. The antibiogram should show the percentage sensitivity of the organisms, commonly isolated organisms against the different sensitivity, which will guide the clinicians for the empirical therapy or for formulating the antibiotic policy. Also, the antibiogram and the antibiotic policy should mention as discussed before about the intrinsic resistance. There should be a note of the intrinsic resistance also in the antibiotic policy and the antibiogram. And in antibiotic policy, there should be a mention of the empirical therapy, prophylactic therapy, and therapeutic outcome. While we say about the empirical therapy, what are the points that needs to be focused? Is whether the patient infectious, which organ is sick, which antibiotics should we use, and what dose should we use? When we say the patient infectious, urgent antibiotic therapy is warranted when the patient is in sepsis within 1 hour of recognition of sepsis. Now, how to know whether the organism is sick for an empirical therapy? Get appropriate cultures. As I said before, it's the basis for the stewardship program. Most rapid method the culture results gets delayed. The most rapid method is the gram staining of the samples. Then we can, from samples like we can from a buffy coat of the blood also can reveal the organisms with polymorphs can indicate infection. Then there are immunological method or serological methods like antigen detection. There are molecular detection methods like PCR. There are MALDI-TOF also. Within seconds, the MALDI-TOF method gives identified organism. And after all, we have the culture methods, but these are the rapid methods that can be made use of for serious cases. As repeat again, I said before, 2 sets of blood cultures should be taken ideally as recommended by standard guidelines studies. And very important to send the cultures before antimicrobial therapy. If the therapy has already been started, then before the next dose of the antibiotic, the culture should be sent. Which antibiotic should we use for this initial empirical broad spectrum should be started, and then de-escalation should be done based on culture results. Just hold me. We'll take a break of a minute. Sorry for the interruption. we were on the slide, which antibiotics should be used. Initially, empirical therapy should be started, and then de-escalation should be done based on the culture results. For cases like tissue penetration, it is important to choose antibiotics that penetrate into the organ concern. For example, ceftriaxone for meningitis, or for resistance, antibiotic choice should be based on the local antibiogram, as said before. Now, the patient has been categorized into four categories. According to these four categories, the treatment should be accordingly. What is the patient type 1? Patient type 1 includes limited use of broad spectrum antimicrobials, no role of antifungal agents. In type 2, the ES-belly infections to be treated with non-pseudomonal antibiotics like group 1 carbapenems or beta-lactam inhibitors can also be preferred for mild ES-belly infection. Then vancomycin ticaprolol is to be used for MRSA. There is no role of antifungal agents in type 2. In type 3, the bacterial infections to be treated with broad spectrum antibiotics like group 2 carbapenems or beta-lactam inhibitor combination with fluoroquinolones. The prophylaxis for fungal infection should be given as per IDS guidelines, that is Infectious Disease Society of America guidelines for patient type 3 infections categories. For category patient type 4, bacterial infection to be treated with novel combination of antibacterials for pan-resistant bacteria and empirical therapy of fungal infection for both stable and unstable patients should be given as per IDS guidelines. So this was just a superficial I have covered about the four categories of the patient. According to the antifungal or the antibacterials should be prescribed. Then we have aware group of who the WHO has classified the antibiotics into 3 classes: access and watch and reserved. The antibiotic consumption should be monitored according to the 3 categories, and focus and our goals should be that the reserve group of antibiotics should be justified for the usage, and it should be monitored, and consumption should be brought at the lowest. As I explained about the 4 categories, if you take the example of bloodstream infections, the guidelines need to be for the same. Regarding the prophylactic antibiotics, especially for the surgery, should be given within 1 hour of surgery, or 1 hour of the incision, to be specific, or within 1 hour of the administration of the anesthesia. So what happens? There is no point in closing the door after the thief has escaped, as you say. So there is no point if you give the antibiotics after 2 to 3 to 4 hours of the incision, or before maybe 4 to 6 hours before of the incision. The percentage of the infections increases in such cases. So it should be given within 1 hour of the incision. And what's been observed in healthcare setting, the patient is in the ward, it is the day before the surgery, he is given the antibiotics, and then is taken for the surgery the next day early morning. Already we are finished up with 8 to 10 hours of the hours, and there is no point in giving the infection or in giving the prophylactic antibiotics. So that's the observation that's been seen in near more than half of the cases that has been audited in my observation. Also, for post-surgery or operation, for days, these prophylactic antibiotics gets continued without any stop. So once the operation is over, once the gap is closed, there is no point in giving the antibiotics. It is indiscriminate, it is irrational, we can lead to resistance. So antibiotics will be given within 1 hour before the incision. For aminoglycosides, it should be given within 2 hours of the incisions, and prophylactic antibiotics should be discontinued within 24 hours at the end of the surgery. We call there are like the care bundles for infection control. We have care bundle for antimicrobial stewardship, like site of infection, the risk stratification of MDROs, the local antibiogram, and de-escalation forms the care bundle for antimicrobial stewardship. What are the principles of antibiotic therapy? For an antibiotic therapy, the toxicity, the pharmacokinetics, the pharmacodynamics, the resistance, the commensals, the colonizations needs to be considered for antibacterial therapy. I said we have care bundles for stewardship. We have 4 moments, like we have 5 moments of hand hygiene. We have 4 moments of antibiotic decision making. What is this 4 moments? First moment, make the diagnosis. Second, culture and empirical therapy should be culture should be done, and empirical therapy should be given. Then third moment is this: stop the drug and change it according to culture results from broad to narrow, or from IV to oral. And fourth moment includes have antibiotics continued for the proper duration. So these are the 4 moments of antibiotic decision making. What are the principles of antibiotic therapy? Let us see. Establish a principle one, establish a rational and accurate differential diagnosis for the patient's illnesses. Differential diagnosis that includes likely bacterial infection. All fevers are not infectious. As you can see from the slide. The fever can be infectious or non-infectious. Non-infectious causes include inflammatory, iatrogenic, endocrine, and other causes. And infectious causes include viral infection, bacterial infection, and fungal infection, others. So accordingly, if it is a bacteremia, it can be continuous or intermittent. It can be septic shock. It can be a specific infection, organ-specific infection like UTI, pneumonia, and others, or abscesses. So according to the syndromic approach should be considered while prescribing for differential diagnosis for prescribing antimicrobial therapy. Failure of this principle one, that is inaccurate differential diagnosis, leads to inappropriate antibiotic prescription. If it is often seen, as you can see from this chart, for malaria and dengue, empirical therapy is being antibacterial therapy is being prescribed. Antibiotic prescription is prescription using high whenever even with the blood smears are positive or the rapid diagnostic tests are positive for malaria or dengue. So the antimicrobial stewardship needs to be followed in such tropical infectious diseases like malaria and dengue, and inappropriate the differential diagnosis needs to be focused. Rapid termination of antibiotic therapy, including disease control or elimination, is the mainstay of antimicrobial stewardship in such tropical diseases. Now, what is empirical? There should be proper selection of empirical therapy. And what is empirical? Choosing antibiotic without knowing precisely which are infecting a patient. Now, how to choose? It depends upon establishing a rational and accurate differential diagnosis. What are the criteria for the same? The agent should be active against the susceptible or the expected pathogen, suspected or the expected pathogen, or the agent should reach this sufficient concentration at the site of the infection and retain its activity at the site of infection. The agent should have an appropriate narrow spectrum. The agent for the empirical therapy should be suited for the prescribed route of administration, and the agent should have a least toxicity compared with an equally effective drug, and agent should have a least cost to compare with equally effective drugs. So that's the criteria. That's the criteria for selecting empirical therapy. What you need actually is the differential diagnosis and the hospital antibiogram. These are the two key factors and key things that we need for empirical therapy. The hospital healthcare setting should have an antimicrobial drug dosage adjustment in organ impairment or adults protocol available. IV to oral guide available. The site-based ICMR guidelines which is available should be in implementation. Duration of treatment guidelines should be available. Local epidemiology-based antibiotic protocol based on antibiogram should be available for UTI, RTI, bloodstream infection, and abdominal infections. Then perioperative antimicrobial guidelines should be in place and should be stringently followed, which is one of the prime reasons for leading towards resistance. Now, what is choosing empirical antibiotics over broad spectrum? What is the study says? The 30-day mortality was about nearly 4% as compared to 14% in standard therapy and extended spectrum therapy. So physicians should assess the risks of drug-resistant pathogens when determining the empirical therapy and should refrain from administering unnecessary extended spectrum antibiotic for patients with community-acquired pneumonia or with a low risk of drug-resistant pathogens. The bioavailability needs to also be taken into consideration for therapy. Like we have bioavailability for per oral antibiotics like linezolid, it is 100%, for levofloxacin 99%, for moxifloxacin is 90%, for penicillin it is 60 to 70%, so for fosfomycin it is 30% to 37%. So bioavailability needs to be taken into consideration for prescription of antimicrobials. Positive cultures without sign and symptoms is another issue. Positive cultures is not always an infection. Especially focus on so in such cases focus on non-sterile positive cultures like from genitourinary, gastroenterite or skin swabs. Differentiate the true infection from the colonization and contamination. Ideally, antibiotics are not required for colonization and contamination, and good stewardship programs should be in place for preventing any irrational usage in such cases. Just sharing here, not usually, these are the never contaminants. Staphylococcus aureus, Streptococcus pyogenes, Streptococcus agalacea are never contaminants. They are true pathogens and very fatal pathogens. While gram-negative like E. coli, Klebsiella, Pseudomonas aeruginosa, gram-negatives are never contaminated isolated from sterile sites. While the contaminants group of organisms includes Cockroach negative Staphylococcus like Streptococcus epidermidis, Bacillus species, Corynebacter species. So when these contaminants are isolated from sterile samples, clinical history needs to be taken into consideration. Repeat samples can be done, should be done if feasible to rule out contamination. What is it? There is a low risk, less than 10%. There is a probability of bacteremia in cases of conditions like uncomplicated cellulitis or lower UTI or CAP or community-acquired pneumonia, fever less than 48 hours. While there is a high probability of bacteremia in cases like osteomyelitis, epidural abscesses, meningitis, septic shock, and catheter-related bloodstream infections. Then this is another concern, asymptomatic bacteria. When even if the patient is not symptomatic, samples are sent for culture and setting, especially usually the urine samples. So the bladder is normally colonized in such in elderly people with E. coli and Klebsiella. A positive urine culture will mislead, and the treatment for such asymptomatic cases is not recommended. It is hard to ignore a positive test, hence a culture should not be sent for asymptomatic cases. Habitual testing should be avoided, especially if colonization is suspected, because it can lead to unnecessary prescription and missing the real diagnosis. So that's the issue. That's the issue. Unnecessary treatment and misdiagnosis can harm the patient and can lead to cross-borne difficile infection or nausea, vomiting, and other such complications. So let us understand this UTI cases in terms of signals. Red means do not test the urine, do not treat it if the urine test was done by someone else or for routine purpose. And while the yellow signals alarms about individualized care, be mindful of the presence of asymptomatic bacteria, seek other causes of for the conditions, and specific UTI symptoms are there that treat or test or treat as usual. Spectrum of antibiotics is very important for empirical therapy. The local antibiotics should be considered by empirical therapy. Choose an antibiotic that covers the most common pathogens and avoid cover with broad spectrum antibiotics as far as possible. Know the spectrum, as we have seen in the when we started with the presentation. We have seen there are bacteriostatic and bactericidal and narrow and broad spectrum antibiotics. So that antibiotics needs to be considered while prescribing antibiotics. There is a lower threshold for empirical therapy for critically ill patients. The host factors that affect the empirical therapy needs to be considered. Consider the patient immune status, the broadened empirical therapy coverage in immunocompromised patients, in neutropenic patients too. In acute pathogenic pathogens, the empirical therapy should be broadened. And also with patients with defects in T cells and B cells. Take an example of vancomycin. What are the indications of empirical vancomycin therapy in febrile neutropenic patients? These indications include hemodynamic instability, positive blood cultures for gram-positive bacteria. So no doubt, in first two cases, order immediately vancomycin in hemodynamic instability or positive blood culture. But if it is a colonization with MRSA or severe, then check the patient's history before prescribing vancomycin. And in cases like severe mucositis or skin and soft tissue infection or catheter-related infection or pneumonia, physical examination is very important. Chest X-ray or CT or will guide for the therapy. So remember this 7 indications to properly start gram-positive coverage. Critical illnesses drastically increases the beta-lactam volume of distribution. So if you can see from this table, in critically ill patient, the beta-lactam antibiotic like imirapenem and peptides and cifepam had a higher volume of distribution as compared to the healthy volunteers. So another principle is the right administration. Sufficient drug not delivered or reached at the site of infection can lead towards resistance. So incorrect administration is associated with poor clinical outcomes. So proper administration is mandatory for good clinical outcomes. Then choosing the right, that was about the right administration, then choosing the right dosage. The site of infection, the causative organisms, and the type of formulation needs to be considered for selecting the right doses and of antibiotics. The first 48 hours is always critical period. Inadequate therapy during the first 48 hours treatment increases the odds of mortality and morbidity. In Enterococcus and Staphylococcus bacteremia, the CART analysis adequate therapy within 48 hours and 44 hours has been observed to reduce the mortality. Then the another principle is the practice de-escalation. So de-escalation is the practice from a broad to narrow spectrum from switch to antibiotics or from IV to oral. For the de-escalation, can be used. As you can see from this present study, that is from the slide, the pro-calcitonin interventions brought about a reduction in the doses of antibiotics by nearly the 4 days from 10 days it gone to the duration of the day, this treatment to 6 days. The mean length of stay decreased in intervention with procalcitonin test, which is an indicator of which is a specific indicator of bacterial infection. So procalcitonin has been proved to be a very useful tool in antimicrobial stewardship program for reducing the duration of antibiotics. Then the other thing is stop date. When the UTI, every antibiotic duration should have a stop date. However, it has been seen for UTI more than 75% of cases it is too long. The therapy is prolonged. Cellulitis also is seen that 80% is too long. Acquired pneumonia, 73% has been observed that this therapy is extended. So there should be a stop date for antibiotic duration for in such cases. Optimize the duration when a correct stop date is placed on antimicrobials. Life is essential, is very good. It doesn't have any difference when the therapy is for 9 days or for 15 to 16 days. There is, as we see from the studies, the 3 different studies have been displayed on this slide. From say median 9 days or 16 days, the results had no difference for Pseudomonas bacteremia. Similarly, was the case observed for other diagnoses like pyelonephritis, intestinal infection, bacteremia, neutropenia fever. When for a short duration and long duration, the results were equal. So shorter is better to conclude. Now, how do you determine the length of the therapy? If you stop your antibiotics early or if you miss the dosage, then the amount of antibiotic available to kill the bacteria is not enough. And the bacteria is still able to replicate. It is easier for bacteria to become resistant if there is a lesser if there is too little antibiotic present. So always complete your course. That is the instruction to be given to the patient, and don't stop just before you feel better. Take them exactly. The patient needs to be instructed that take them exactly as prescribed. Do not share the antibiotics. Do not save them for later, and do not take antibiotics for prescribed which is for someone else. The condition differs from person to person. Oh, now oral administration is a new IV. That is a new mantra. Should be followed. Why oral administration? Because it's very convenient to administer. There is no IV line. There is no skin contact. There is no healthcare exposure. So lesser chances of exposure to the infections by contact or direct or indirect route. Fewer side effects like as compared to IV infusions like thrombophlebitis. There is no fluid overload. Think about IV antibiotics, high sodium contact. So there is often is an issue with the IV, the fluid overload. That is not the case with the oral administration. Then there is also a cost saving with oral antibiotics. And then good patient education is the key for improving the adherence towards oral. Often the patients pressurizes to the clinicians for the IV antibiotics. Hence, in such cases, patient education is important. If therapy is not working, consider the source control and alternative diagnosis before blaming the resistance and broadening the therapy. Before broadening the therapy, identify the source and control it. Inappropriate source control is considered with the highest mortality, regardless of the therapy. Source control is for sepsis. The source can be in case of from head and neck, from sinusitis or dental abscesses or necrotic infection, from heart, from endocarditis, or from abdomen, and other such feature that's source possible source chances of sources in cases of sepsis. The 5 steps towards a successful personalized approach for source control include maximize the effort for diagnosis. Then second is a multidisciplinary management. Third is prompt but not aggressive treatment. Then resolve but not excessive treatment, and continuous reassessment. These are the 5 steps towards a personalized approach for source control. Then distinguish new infection from the failure of initial therapy. New infections are experienced in hospital settings, it will start from resolving the previous infection, should be evaluated differently from a patient who never responds to initial therapy. Never one set of infections after should be this is the concern of a new infection rather than a persistence of the original infection. So is it reasonable to treat empirically with a broader spectrum antibiotics to target the MDROs? Sharing just a slide for which is a very important slide for the clinicians for the which could guide them for the options for the carbamazepine resistance, gram-negative bacterial infections. For example, take an antibiotic like ceftazidime, iobactam. When we do a carbamazepine detection test on a gene expert or on a biofire, wherein we get the carbamazepine resistant enzymes like KPC, IMP, VIM, NDM, and oxalate. So in such cases, ceftazidime is active against KPC and oxalate, but is not active against NDM. That should be considered. It is also not active. Iobactam is also not active against Acinetobacter or Centropomus. So if you say take the examples of Meropenem, Vaporbactam, it is active against KPC, but not against NDM, oxa for another group of organisms. We take the fosfomycin, it is active against KPC, NDM, oxa, but variable against Pseudomonas and not active against Acinetobacter and Pseudomonas. So these treatment options needs to be considered for prescription of antimicrobials. Now we will move towards antimicrobial stewardship strategies and surveillance. Antibiotics are transferred to practice of medicine, but with recent antimicrobial resistance are having a serious adverse effects, which is occurring roughly nearly 20% of the hospital patients who receive them, which is leading to increased morbidity, mortality because of the treatment failures, then cross-linked difficult infections, adverse complications, antibiotic resistance, hospital costs, and increased length of stay. Now, what is the solution for these issues? The solution is antimicrobial stewardship. What happened in 2014 that CDC, that Center for Disease Control, called on all the hospitals in the US and to help the hospital achieve the goal of stewardship. The core elements of the stewardship program has been delineated and it outlines the components that are associated with successful programs. We'll see the core elements in the next slides. Stewardship program provides strategies for rationalizing the usage of antimicrobials in the hospital. What is stewardship? That is right antibiotic for the right patient at the right time, for the right dosage, for the right duration, to the right route, for the right timing, the right frequency, and for the right patient. That is the antimicrobial stewardship. What is core? What are the core elements? There is a leadership commitment. There are 7 core elements for stewardship program. The first most important is the leadership commitment. Leadership to provide the dedicated necessary human, financial, and IT resources for this stewardship program. As per MBBS, it has not been made, and it is now made as a mandatory component of MBBS accreditation for hospitals. So these core elements of a stewardship program should be in place, wherein the leadership is commitment is very important to dedicate necessary resources. And accountability. Appoint a leader or a co-leader such as an ID physician or a clinical pharmacist who are responsible for running the antimicrobial stewardship program. Then appoint a pharmacist who is ideally is the co-leader or a microbiologist or who is the co-leader for the stewardship program. Help implement the efforts to improve the antibiotic usage. Implement the antimicrobial stewardship interventions such as prospective audits or feedbacks or pre-authorization to improve the antibiotic usage. Then track the antimicrobial consumption, the compliance towards the antibiotic policy, the impact of the interventions, and other such outcomes like the impact of the program on multi-drug resistant organisms like resistant diffusion infections. Track such interventions, impact of such interventions, and report it. The next element is reporting. Regularly report this information on usage and resistance to stakeholders like prescribers, the pharmacists, the nurses, and the hospital leadership. Then education. Educate the prescribers, the pharmacists, the nurses, and patients about the adverse reaction from antibiotics, the resistance, and the prescription. Now we are having an antimicrobial global World Antimicrobial Awareness Week in the 3rd week of November from 18 to 24. So this such weeks can be used as an opportunity for education among the healthcare personnel and the stakeholders against antimicrobial resistance and towards antimicrobial stewardship. Let us see in detail about these core elements. The leadership commitments includes giving stewardship program leaders time to manage the program. Many times it's often there are issues like leaders like ID physicians and pharmacists, they don't have sufficient time. So the leadership should give them sufficient time to manage the program and conduct the interventions, providing the resources like IT resources, the human resources, the other such resources to operate the program as needed effectively. Have regular meetings with the leaders of the stewardship program to assess the resources needed to accomplish the goals for stewardship. Appoint a senior leader who can be a high physician or a senior clinical pharmacist to serve as a point of contact or champion for the stewardship program to help ensure that the stewardship program has resources and support to accomplish its mission. Then report the stewardship activities and outcomes on a regular basis with the stakeholders and to the senior leadership and the stakeholders. The next thing is accountability. Stewardship program must have a designated leader who can be an ID physician or a clinical pharmacist. Most hospitals have a co-leadership model, which is turning very effective, like ID physician and clinical pharmacist who are working together towards the stewardship. Programs with co-leaders have a clear should have a clear delineation of their responsibilities. Regular stewardship rounds for the co-leaders is a must. We also call this a handshake stewardship, wherein the co-leaders like ID physicians and the clinical pharmacists have case discussions with the clinicians and the pharmacists and the nurses towards the antimicrobial stewardship strategies. So this is the team for the stewardship program. The core team includes the ID physician, the pharmacist, the senior physicians, the clinical microbiologist, and the IT professionals. When the physicians facilitate the collaboration between the AMS and the clinical teams, the help the guideline for the clinical guideline implementation. Pharmacists educate, promote, and develop, implement, and audit the pharmacy, the antimicrobial policies, implement compliance. Then the ID physicians formulary help in for development of the antibiotic policy, the formulary development of the antibiotics, and they review the antimicrobials on a regular intervals for antibiotic policy. Clinical microbiologists also play a key role for the point of care review and interventions on the basis of the culture and sensitivity testings and enforcement of antimicrobial restrictions. IT professionals, as has been observed, often poor IT resources has become a reason he become a hindrance towards a stewardship program. So if you have a good IT system in place to monitor, to track the consumption of the antibiotics towards then the resistance patterns of the antibiotics, it will prove very beneficial for the healthcare setting for running the stewardship program. So that is about physician, pharmacist, microbiologist, and IT professionals to work aggressively towards the stewardship program. If you see the pharmacy expertise, these highly effective hospital stewardship programs have a strong engagement of pharmacists. It is important to identify pharmacists who is mostly PharmD or MD pharma who is empowered to lead the implementation effort towards antibiotic usage. Stewardship intervention should improve the patient outcomes, and initial assessment of the prescription should be developed to identify the potential target for intervention. So there are different interventions for stewardship. One is priority interventions to improve the usage, then infection-based interventions, then clinician-based interventions, then pharmacy-based interventions, then microbiology-based interventions, and nursing-based interventions. Won't go into details of the interventions. Microbiology is based on culture sensitivity. Nursing is based on the direct observation of patient clinical conditions. Pharmacy intervention include the pharmacokinetics and pharmacodynamics, while the provider's intervention is based on the clinical conditions for the rational antibiotic usage. What are the checklist for the assessment of the stewardship program? The leadership support, the accountability, the drug expertise, the pharmacy expertise, and others. So the assessment should be done, and it should be regularly done at every quarterly or 6 monthly to assess the impact of the intervention. Now, what are those interventions? I said before, priority intervention. What are these priority interventions? Prospective audit and feedback. Do an audit of the compliance towards the antibiotic policy. It should be an external review. It should the team of the professionals who are doing the audit should be an external team. It should not be the treating team. This is what differs the prospective audit of antimicrobial stewardship from the timeout. Antibiotic timeout is different. It is done by the treating team, while the audit of the stewardship program is done by a different team other than the treating team. Then pre-authorization. All the clinicians or the prescriber should take a formal approval of the ID physician or the clinical pharmacist or the microbiologist to prior to prescription of certain high-end antibiotics, like say for example colistin or tetracycline or polymyxin or fosfomycin and others. So such a high restricted group of antibiotics requires pre-authorization for the prescribers. Then there should be availability to facilitate specific treatment guidelines, or we call it an antibiotic policy, which should be prepared on the basis of the local hospital antibiogram and should be available readily for the clinicians to prescribe therapies. Now, what are the antibiotics which require prevention should be, because how they should be selected? You should be selected on variables such as broad spectrum coverage or potential to promote resistance or potential for misuse or high cost or serious adverse effects. So how to develop the antibiotic guidelines? That is another intervention. Identify the most important disease syndrome in the hospital requiring guidelines. Integrate the care bundle guidance of the specific clinical syndrome. Evaluate the most common pathogens causing those specific syndromes. Evaluate the most effective antimicrobial agents against those clinical syndromes. Review it according to taking on the guidelines such as IDSA guidelines or NICE guidelines and adapt it according to those recommendations. And integrate all the information into an algorithm or a table or a protocol, include headers and footers as required, and then share it with the stakeholders. Emphasize the importance of considering patient factors like immunosuppression or immunocompromise, the metabolism, pharmacokinetics, the pharmacokinetics, and pharmacodynamics in those guidelines. These guidelines should answer the below things like such as what should be the most likely cause of infection for some conditions, how severe is the infection, is the patient immunosuppressed, or what should be therapy, what's the risk of infection with drug resistant organisms for some conditions. That condition should be addressed in antibiotic policy. There should be infection based interventions, like we have seen that we have stratification of the patients into 4 categories and according to different clinical syndromes. So such infection-based interventions should be implemented as infection-based interventions. We also have other infection-based interventions like sepsis or staph aureus infection that should be implemented as a part of the strategy of the antimicrobial stewardship program. Now, provider-based intervention. As I said before, antibiotic timeout is also a provider-based intervention. What does a provider review of antibiotics should focus on? It should focus on whether the patient have an infection that would respond to antibiotics, have proper cultures and diagnosis tests been performed, has there been a switch of antibiotics from class to class according to culture results, has been there a switch from IV to oral, has been there a switch or de-escalation from broad to narrow. So that needs to be addressed in discussions of antibiotic timeout, which comes under the provider-based interventions. Then what does the pharmacy-based intervention include? Pharmacy-based intervention includes whether there's a documentation of the indications for antibiotics, whether there has been automatic changes from IV to oral, whether there has been dose adjustment done according to pharmacokinetics and pharmacodynamics, whether there has been dose optimization, whether there has been a duplicative therapy alerts. Now, most of the times it has been seen even for with carbapenems, metronidazole is being prescribed. So such duplication should be avoided and duplicative therapy alerts should be given to the clinicians. Time-sensitive automatic stop orders should be in place, and detection and prevention of antibiotic-related drug-to-drug interactions should be, the information should be provided to the clinicians. But the next thing is de-escalation. If the hospital's empirical antibiotic treatment guidelines have not been followed without a well-reasoned, the pharmacist should recommend that the broad-spectrum therapy should be de-escalated in clinical stable patients. During empirical therapy, a narrow-spectrum antibiotic should be chosen as far as possible in accordance with the hospital guidelines. Once the microbiology results are available, the pharmacist will encourage the change to definitive therapy with a narrow-spectrum antibiotic pathogen-directed treatment as possible based on sensitive results. Now, what is the criteria for de-escalation by switching to narrow spectrum antibiotics? For empirical therapy, the criteria for de-escalation includes when the temperature drops down, the patient becomes stable, is not on inotrope, the systolic BP becomes stable, the patient is not mechanical ventilated, or respiratory rates is not becomes to normal. In such cases, in such empirical therapy, the antibiotic therapy can be de-escalated. While what is the criteria for de-escalation? Why discontinuation? That was from broad to narrow. For discontinuation, the criteria for empirical therapy includes whether the empirical therapy is completed, the therapy has been completed its course, there is no indication or of any infectious disease identified. Such cases, the empirical therapy can be de-escalated. Why discontinuation? While for definitive therapy, based on cultural and sensitive results, the de-escalation to narrow spectrum antibiotics should be done. Now let's see about the other strategy of antibiotic stewardship, that is IV to oral conversion. IV to oral conversion of the same antibiotics is a relatively simple intervention, and pharmacists should routinely encourage this IV to oral conversion of antibiotics. But we have seen the antibiotics with a good bioavailability. So such a good antibiotics with such good bioavailability should be the information should be shared with the clinic prescribers for the same for the IV to oral conversions. For example, fluoroquinolones are highly bioavailable drugs, as we have seen before. That this can be easily converted from IV to oral route as indicated. Advantages of the oral therapy, I said before, is the ease of administration, lesser complication as of IVs like thrombophlebitis, and drug cost savings. Dose optimization. Dose optimization is another strategy in a stewardship program. Pharmacist expertise in relation to pharmacokinetics and pharmacodynamic principles is beneficial when reviewing the antibiotic regimens for dose optimization. Dose optimization can be implemented by pharmacists on the basis of deviations from the recommended doses and schedules, and the pharmacist could make recommendations for optimized doses to the prescribers. However, in critical ill patient, dose optimization by therapeutic drug monitor will help ensure adequacy of treatment. So that was about the different strategies, the different interventions. How to now? What about tracking? Measurement is necessary to critical to identify the opportunities for improvement and to assess the impact of our intervention. There should be key performance indicators for the stewardship program to assess the impact of our intervention. What are these key performance indicators in stewardship program? These are either process measures or outcome measures. The process measures or the process key performance indicators include in stewardship program antibiotic consumption. Monitoring the antimicrobial consumption is a very important key performance indicator of stewardship program. So antimicrobial consumption can be monitored in terms of defined daily doses, the days of therapy, the length of therapy. Then the other process key performance indicators include appropriateness of antibiotic usage, that is, doing assessment or audits towards compliance towards the antibiotic policies, whether the prescribers are adhering to the hospital guidelines. What is the rate of acceptance of interventions? What is the difference? What is the change that has been brought about in the knowledge, attitude, and practices of the prescribers? So that is the key performance indicators under the category of process measures. That is antibiotic consumption and to antibiotic policy compliance and the CAP assessment, that is knowledge, attitude, and practices. If we see the outcome measures, outcome key performance indicators, it includes the rate of antimicrobial resistant pathogens like MRSA, ESBL, VRE, CRE, also Clostridium difficile infection rate. So that is about the outcome key performance indicators. If you see the decrease in the rates of this resistant pathogens, that means the stewardship program is moving positively. Then, if there's a decrease in the length of the stay, it's a positive outcome of antimicrobial stewardship program. Also, the unexpected readmission is decreased, is a positive outcome of AMS program. Also, similar is the case with the antibiotic expenditure. There's an antibiotic expenditure, lesser cost involved in the antibiotic expenses, is a positive outcome of stewardship program. It is we'll explain in just short about the days of therapy, which is a process key performance indicator for consumption. What is the days of therapy in defined doses and length of therapy? Days of therapy denotes the number of days that the patient receives at least one antibiotic. Say the patient is on two antibiotics like cefazolin and carbapenem or peptides. Cefazolin for 3 days, peptides for 3 days. So 3 plus 3 is 6. 6 are the days of therapy. So data of days of therapy requires patient level data from electronic health records. Now this is another limitation. So to put this strategy into practice, that is electronic health record or manual records needs to be in place for this days of therapy, which often becomes cumbersome. If done, it's a very ideal. It's a good strategy for monitoring the consumption. And defined daily doses. WHO has its defined standard defined daily dosage for each of the antibiotics. So if we should monitor the antibiotic consumption, and we should see that the defined daily doses are not crossed. It's not or it's not increased as compared to the DDD. The consumption should not increase as compared to DDD as prescribed by the WHO. So the healthcare settings should monitor the consumption of antibiotics in terms of defined daily doses. Then length of therapy. Length of therapy includes denotes the number of days a patient receives antibiotic therapy, irrespective of the number of antibiotics. Say, like I said, cefazolin and peptide 3 plus 3. So if the patient was on antibiotics just for 4 days, which include both of the drugs, so 4 days is the length of therapy. So length of therapy provides a true duration of the antibiotic therapy per discharge. Said before, we should do the healthcare system should do the team should do a point prevalence surveys. What is a point prevalence survey? A point prevalence survey helps in assessing the appropriateness, that is the compliance with the antibiotic policy on a particular day in a particular area, like in a ward or ICU across a hospital. This survey is easily feasible. Then it doesn't require any electronic information systems and or other such software systems. So point of prevalence survey is a very good strategy of stewardship program. Length of stay is relatively easy to obtain. It can be also done used as a measure of clinical improvement in stewardship program. Then antibiotic expenditure, that is financial impact of the stewardship program, what should be measured. In order to justify the continued administrative support, antibiotic costs should be measured, which also highlights the cost of savings for the hospitals. Now, tracking the key performance indicators. We have seen this key performance indicators of stewardship program. AMS programs must focus on high-profile antibiotics, resistant antibiotics, restricted antibiotics, the multi-drug resistant pathogens, the high-risk populations, the hospital high-risk areas. The AMS program must create graphs, display the KPI trends over time, the trend before and after implementation. So that was about tracking the key performance indicators. That this key performance data should be reported to the stakeholders. The stewardship program should provide regular updates to the prescribers, the pharmacists, the nurses, and the leadership on process and outcome measures. This includes the resistance, the compliance towards the antibiotic policy, the antibiotic consumption, and other such results of strategies, or key performance indicators. This can also be done through a hospital newsletter, both on infection control or on antibiotic booklets. It's that the eyes can't see what the mind doesn't know. Education is a very key component of the efforts, of the comprehensive efforts to improve hospital antibiotic use. There are many ways we can provide education on antibiotic usage, such as didactic presentations, which can be done in a formal or informal settings. Now, in our project, in our stewardship program, often we get very poor. We don't get the participation of doctors and nurses on classroom sessions. So what we do, our project team does, we go bed to bed. We have case discussion with the doctors. We have bedside discussion with the nurses, and we have a presentation on the bedside. Along with the classroom sessions, we pass messages through posters, flyers, and newsletters. In our project, electronic communication to the staff groups is another way that can help to provide education and share information on antibiotic usage. Education is the most effective when it is paired with interventions and measurement of outcomes, and case-based education and discussions or prospective audit with feedback and pre-authorization. What is the basic step for that? We have seen the core elements of the stewardship program. What is the basic step for running the stewardship program? Perform a situation analysis. The program differs from hospital to hospital. Perform a situation analysis, do a SWOT analysis, obtain approval for the aims for this AMS program from the leadership. That's very important to gain support of the leadership. Obtain approval for them, have on the basis of the SWOT analysis, assemble an AMS team, set goals, set the interventions, select the key performance indicators, implement the interventions, educate the team, the healthcare, the stakeholders, and train them, monitor the interventions, and report its progress to the stakeholders. Now, how to sustain this AMS program? The AMS team leaders are responsible for the long-term management of the program, and it includes monitoring and assessing the performance at regular intervals, reporting the performance to the stakeholders, modifying and adapting the program as needed, and continuing AMS education. Pre-specified process and outcome measures should be tracked on a regular, as we discussed, to assess the performance of the program. For a sustainable AMS program, long-term trends are as important as initial changes. Then adapt this AMS program as we are on the basis of the results. The AMS team leader should work with the microbiologist and pharmacist. It should be they should be in a very close touch to for wherever feasible. The dose optimization, for certain drugs and for certain patients, drug dosage is determined on the basis of certain parameters like body weight or surface area or age or creatinine clearance. That should be taken into consideration while for dose optimization. As we can see from the table, according to body weight, the total body weight, the adjusted body weight, the dosage differs from the antibiotic to antibiotics. That should be taken into consideration while prescription. Then loading dose, there are different classes of antibiotics like time-dependent antibiotics, concentration-dependent antibiotics, and accordingly the loading dose should be determined, and also the maintenance dose. Prolonged infusion or continuing infusion was associated with a higher clinical improvement and lower mortality for time-dependent antibiotics like beta-lactam group of antibiotics. For concentration-dependent antibiotics also, the timing or the duration of the antibiotic. So as you can see from this graph, for half an hour infusion, it was for a period of 4.5 hours. The antibiotics was more than the MSCs. However, for the 3-hour infusion, the Cmax was about nearly 40, and the half-life was about nearly 6.5 hours. So more the prolonged the infusion, the better is the concentration of the antibiotic about the required MSC. Very important, choosing the right dilution is also very important. For fosmicin, do not use 0.9% NS for dilution. The correct should be followed like it should be 4 grams per 134 milligram of sodium. Similar for amphotericin, do not use an NS for dilution. Daptomycin, do not use the 5% daptomycin for dilution. So that's the other thing, that the dilution needs to be taken into consideration for the prescription. Choose the right dosage. Dosage depends on the site of infection, the organisms, and type of formulation. Selection for empirical therapy is very important, or to have a right choice for the right choice of the right selection of the empirical therapy. See that what is the diagnosis, as we discussed this before. What is the microbiology? What is the culture sensitive report? What is the correct dosage? Use the local antibiogram for empirical therapy. Make a diagnosis, use full therapeutic dosage, and do not treat cases such as ETS colonization for VAP, or do not have a catheter tip for central blood-some infections, or bacteria for UTI infections. So asymptomatic cases or such samples should be avoided for testings. Every hospital should have their own antimicrobial policy for common syndromes. They should have their antibiotic policy for a particular type of diseases, for against particular organisms, the empirical therapy, the alternatives, and the comments or remarks for the same. Optimize the duration of therapy can be easily important, because many studies show that infections are often treated for longer, as we have seen before. So shorter that is the better. I repeat, de-escalation should be practiced, and start for nice guidelines should be followed for, as you can see from the chart, for the sepsis cases. Start smart and then focus based on the nice guidelines. If infection is suspected, administer the antibiotics within 1 hour as per the local guideline. Take samples and advise for the review at 48 to 72 hours from the treatment. Antimicrobial review should be done for stoppage, or for IV to oral switch, or for switching to antibiotics, or to continue, or to re-review. What's the timing for switching the therapy? When the person is on a therapy, there are 3 stages: phase 1, 2, and 3. In the first few days, the patient is clinically unstable, but for the next 2 to 3 days, the patient is clinically stable, and after 7 days, the patient usually gets discharged. So the correct time for switching the therapy is usually just 2 to 3 days when the patient is clinically stable, and we have a sensitive report in hand where we can change the patient from empirical to lab-based therapy. So that was about the different strategies. Coming back to the last slides, antimicrobial resistance leads to increased morbidity and mortality. So this is restricted to resistant antibiotics like meropenem or colistin, TGS, and polymyxin, or vancoticol, amount of 40 gram positives, or for the echinocandins against the antifungal. This should be reserved or restricted usage, and then justification needs to be given prior to prescription. So to summarize, we have seen about antibiotics, how to interpret the reports. We have seen the antimicrobial stewardship, these interventions, how to monitor it. Let us summarize. Antibiotics have become major components of healthcare interventions. The usage and misuse of antibiotics have led to emergence of multi-drug resistant pathogens like MRSA, VRNC, and others. Infection control staff can help prevent the irrational usage of antibiotics and encourage the implementation of strategies that reduce the development of antimicrobial resistance. Antimicrobial stewardship programs are coordinated. It is a multidisciplinary team that's and coordinated interventions at a facility level, which is intended to improve and monitor the appropriate uses of antibiotics. The healthcare managers and practitioners should encourage and participate in efforts and implementing a facility-based stewardship program. Broad-spectrum antibiotics should not be prescribed as surgical prophylaxis unless it is indicated. Right drugs should be given against the right bug for the right patient at the right dosage, at the right duration, for the frequency, at the right timing. Proper time interval between the doses needs to be followed. AMS can be achieved, that is antimicrobial stewardship, can be established by following steps such as performing situational analysis, that is SWOT analysis, that is strength, weakness, opportunity, challenges analysis, forming a team, brainstorming, setting the key performing indicators, selecting the interventions as feasible, setting the goals, education, and monitoring. So that was all about in today's my session for about antimicrobial stewardship. I thanks all the participants for their kind attention, and I'm open to the last few 5-10 minutes for the questions and answers.